Welcome to the all viewers and well-wishers of the world. The purpose of my lecture is learn the knowledge from the word and return the knowledge to the world. Motto of my life is learn, earn and return. I have learned a lot, earned a lot. Now it's time to return a lot to the world. The topic of today is Tinea Cruris, which is also called Jock itch. First of all, we should know something about tinea in general. Tinea is a common fungal skin infection, also called ringworm tinea. It affects any part of the skin on the body from head to toe. Ringworm is not caused by a worm. This fungal infection forms a ring-shaped rash, so it is called ringworm. Other similar rashes can look like ringworm, like spider bites, nubular eczema, and Lyme disease, but these are not the fungal infection as the tinea or the ringworm. These are not very serious problem, but they make the person uncomfortable. So here one can see the tinea infection. It can be anywhere on the body from head to toe, and it gives this ring-like appearance of the rash. For that reason, it is called ringworm. As one can see, it is nearly the ring shape. Now, coming to the topic of today, it is Tinea Cruris. Tinea Cruris is also called crotch itch. Crotch is an area where leg joins the body. Rot means decay. Dhobi itch, eczema marginatum, gym itch, or jock itch. Sometimes it is called jock rot, scrot rot, or ringworm of the groin, which is given in the different books by the different names. It is contagious superficial fungal infection of the inguinal area, involves the groin, perianal, and perineal area, plus upper thighs and the buttocks also. These dermatophytes affect the keratinized structure like hair and the stratum corneum of the epidermis. A rash is a lesion which is intensely itchy, red raised with a scaly, well-defined curved border. As one can see and appreciate here, these are the areas which are involved in by this Tinea Cruris. It is mainly in the men and in the hot humid climates in the summer and in tropical areas, seen in the people living in groups in tight quarters, athlete teams, troops, ship crews, inmates of the institution are also very much involved. Symptoms are itch, rash in the groin. Risk factors are excessive sweating, diabetes, and obesity. And the diagnostic method is by microscopy and the culture of the skin scraping. Medication is the topical antifungal medication mostly. Here one can see the classical lesion of Tinea Cruris. As one can see, it is involving the inguinal area and the upper thigh, and here also the inguinal area and the upper thigh, and also it extends up to the buttocks also. Now, epidemiology, Tinea Cruris is common in developing and tropical countries. Why? Because due to the climates with the high temperatures and increased humidity, which lead to this problem more. 20 to 25% of the world population is affected by this disease. It is the second most common clinical presentation for the dermatophytosis. It is seen in adolescents and the adult males mainly, but uncommon in children. One thing one have to keep in mind, it is seen mainly in the men those who wear the underwear and there is sweating there, and that is very prone to have this problem. Now, the pathophysiology of the disease is the dermatophytes organism use its proteinase enzymes, that is to digest the keratin found in the skin's stratum corneum. So that is the food. Keratin is the food of them. In histopathology, there are characteristic findings include branching of the non-branching septate. There are branching or non-branching septate hyphae and possible arthroconidiospores. Now, among the causes, dermatophytes belonging to the three genera Trichophyton, Epidermophyton, and Microsporum, which are collectively called MET. The type of the fungus involved vary in the different parts of the world, like Trichophyton rubrum and Epidermophyton floccosum are common in the New Zealand, and less commonly Trichophyton mentagrophytes, which is of animal origin, and Trichophyton verrucosum are involved here. Rarely involved is Microsporum galeni. Epidermophyton floccosum can survive longer on the rugs, shower stalls, locker room floors, and that cause the rash limited to the groin or perineal area. Here one can see the causative fungi. These are Trichophyton rubrum, Trichophyton mentagrophytes, and Epidermophyton floccosum, and Microsporum galeni. These have got the different shapes, and from their shapes under the microscope, one can recognize that which type of the fungus is involved in this area and in this patient. Now, it is easier to stay awake till 6 a.m. than to wake up at 6 a.m. So that is a bit difficult. Now, coming to the transmission of the disease, it is contagious and can be transmitted from person to person by skin to skin contact, that is called direct contact, or it can be indirect contact by contact with the contaminated sports clothing and the sharing towels, which are called the fomites, the belonging of the patients. It can be even from the infected dogs or the cats, so the spread is of animal origin also. Primary source and mode of the transmission is geophilic. Geo mean soil, so that is residing in the soil, can be zoophilic from the animals, and anthropophilic, that is the human patients, those who are harboring this fungus, can be the reason of transmission. Autoinfection of the dermatophytes is also possible, and especially in the Tinea cruris, as foot to groin spread. It is the infection of the foot which can spread to the groin by the scratching and touching the feet. So here one can see the direct contact, physical, and indirect contact by using the fomites or the belonging of the patient, and from the animal contact, the animals who are the reservoir of this problem, that can transmit from infected person to the healthy person. Now, risk factors. Tinea cruris is often associated with athlete foot and the fungal nail infections because rubbing from the clothing, occlusive clothing, sharing of the infected towels or the sports clothing, these are the risk factors. Then excessive sweating, excessive perspiration, patient of the diabetes, obesity or a obese patient, improper hygiene of the patient, immunocompromised patient, low socioeconomic status, so not personal cleaning well. Athletes involved in the contact sports, so having the direct physical contact, and genetics can also play a role. Now, what are the clinical manifestation of this disease? That number one is the rash. It is sharply defined, annular, round, lesions, inflamed, raised, inflamed borders with vesicles, reddish brown centers. Erythematous mean red, scaly in interdigenous area. The rash may appear reddish, tan, or brown with flaking, rippling, peeling, or cracking. There may be some blistering and weeping, oozing of some fluid from the lesions. Center may be light in color. The distribution is usually on the both sides of the groin. Rash can reach near to the anus if that start spreading. So here one can see the classical rash, the margin, the center is lighter and inflammatory halo that is also present in the Tinea cruris. In hairy person, hair follicles become inflamed that result in bumps, papules, nodules, and pustules within the plaque, confluent plaque patches spreading to the thigh, buttocks, and the abdomen, as I have already shown you. Infection seen on the scrotum, inner thigh, in groin and perineal area. Intense itching is there in groin that can extend to the anus. The plaque reach scrotum in men and labia majora and mons pubis in the woman. Penis is usually spared unless immunodeficiency or the use of the steroid. So here one can see the Tinea cruris, jock itch, or the ringworm of the groin, sharply demarcated lesions, raised erythematous margin, thin, dry epidermal scaling is there. Patient complains initially of intense pruritus, maceration, and superinfection is there, so that lesion become painful. The genital area and the medial upper thigh is involved, that is extension to the pubic area, lower abdomen, buttock, and perianal area is there. Scrotum is minimally affected. I have told you that is only when there is immunocompromised patient. So Tinea rubrum, Trichophyton rubrum, Trichophyton mentagrophytes were interdigital, and Epidermophyton floccosum are the main culprit for causing this infection. Now, what are the complications of this disease? It occurs only complication when there is failure of therapy and recurrence due to the reinfection from the close contacts. There is autoinfection from the separate body location like Tinea corporis or Tinea other variety. Infection by uncommon species such as zoonoses and misdiagnosis is also there. Drug resistance is there. Non-adherence to the management plan that also lead to the complication, and steroid use suppress the physical signs, making the diagnosis difficult. So, continuing the complication, it also results in skin atrophy and telangiectasis. Secondary bacterial infection is there. Majocchi's granuloma, where dermatophytes disseminate into the subcutaneous tissue. Usually that deeper or subcutaneous tissue is not involved. When it is involved, there is Majocchi's granuloma. It is secondary to the skin breakdown, immunosuppression, or the topical steroid use which lead to this Majewski's granuloma. A dermatophytid reaction due to allergic response at a separate location from the original tinea site is there, that is called ID reaction. So here one can see the tinea pedis, that is somewhere there, or it is Tinea cruris somewhere in the groin area, that lead to the autoexematization. Delayed type of the hypersensitivity reaction occurs. So the ID reaction occurs that resolves with the treatment of the primary infection. If we treat the Tinea cruris, we will be able to get rid of ID reaction. Now, coming to the diagnosis, there are 4 classes of diagnosis. Number 1, history and clinical examination. Number 2, potassium hydroxide preparation. Number 3, fungus culture. And number 4 is the skin biopsy. First is the history and clinical examination. History for the risk factor or the clinical appearance of the lesion is there. An erythematous, scaly, annular plaque with a raised leading edge and central clearing is the classical lesion. It can be visualized extended anywhere from the groin, upper thigh, and perineum to the perianal region. If the lesion weep, likely caused by a yeast such as the Candida albicans, and it is not by the dermatophyte, especially if it is in a woman, so you have to consider the Candida infection also. The second part of the diagnosis is potassium hydroxide preparation. That is, one do place the tissue or the sample on a glass slide at 10 to 20% of the potassium hydroxide, because it dissolves the keratin to help clear the tissue from the fungal spore and the hyphae. Gentle heating also dissolves the keratin. Now add cover slip, place the slide under the light microscope and examine. Potassium hydroxide mounts are procured with a scalpel scraping technique to get it from the affected area by the scalpel and use in the potassium hydroxide preparation. A cellophane adhesive tape method can also be used. So here one can see the potassium hydroxide, and one can also appreciate the hyphae seen in the potassium hydroxide preparation, as one can appreciate that. And in fungal culture, one can have the culture and we can have the fungal plate, and from there we can take the specimen and do the direct microscopy to identify the fungal, so that is called fungal identification. Now, the third method is fungus culture, that is the gold standard. I have already shown you the culture of the dermatophyte. From skin scraping, fungus grows slowly. Culture results are positive only after 10 to 14 days if grown on seborrheic dextrose agar. It provides identification of the causative organism by examining morphology of the fungus. And the last is skin biopsy. It is done if other ways fail to see the characteristic histology changes of the tissue involved. Do the periodic acid shift PS stain and take the sample from the leading edge of the lesion for proper collection of the infected skin. So here one can identify the fungus from the culture plates, that is Trichophyton rubrum, Trichophyton mentagrophytes looks like this, Epidermophyton flocculosum look like this, and Microsporum galeni are like this. I have already shown you these in the causes of the problem. Here one can see the infection, the histology, the biopsy, and the hyphae at PS positive present in the compact orthokeratotic layer, as one can see the hyphae and the spores positive in PAS stain that can be seen and to confirm the diagnosis.